Welcome to Webinar Wednesday. This week's presentation features expert Matt Dummert, a certified healthcare technology manager and academic instructor at IUPUI, Marquette University, and the Medical College of Wisconsin. Matt has more than 20 years experience in clinical engineering and HTM and will provide a meaningful structure for evaluating healthcare technology for investment or purchase through a technical, financial, and strategic assessment. Webinar Wednesday would like to thank our sponsor, MTMI. Medical Technology Management Institute is a global education provider serving medical and imaging professionals, including technologists, sonographers, medical physicists, physicians, and biomedical technicians. MTMI high-quality consulting services, cross-training, and CE programs are offered as webinars or in classroom and are taught by experts with clinical experience in their field. MTMI's newest biomedical program is a 4-day CBET exam review scheduled in Houston on August 16th and in Milwaukee on October 4th. It is also available as a webinar. For more information, please visit mtmi.net. A few announcements before we get started. Please join us for continuing education, networking, and vendor engagement opportunities at our next HTM Mixer coming up on September 9th and 10th in Kansas City. Please visit htmmixer.com for more details, registration, and our steps to a safe and clean meeting environment. While you're there, make sure to sign up for our newsletter so you always have the most up-to-date information. Let's give one lucky attendee the opportunity to win a fun new Webinar Wednesday t-shirt by answering the following question. How many credits has MTMI awarded in the past 32 years? You can find the answer by visiting our sponsor's website. Please use the questions feature on the GoToWebinar dashboard to submit your answer. As always, today's webinar is eligible for one continuing education credit from the ACI. You can obtain your CE certificate by completing the post-webinar survey. More details on this at the end of today's webinar. We will wrap up today with a live Q&A session. You can submit your questions at any time during the webinar by using the questions feature on your webinar dashboard. We'll get through as many attendee questions as time allows. As I mentioned earlier, our speaker today is Matt Dummert. Matt, you may begin whenever you are ready.
All right. Well, thanks everyone for having me for this webinar. Thanks to all those that are attending. The topic for today is healthcare technology assessment. And what exactly that means is what we're going to go through, but I will say that this is a very broad topic and we're going to cover a lot of ground. And I'm going to try not to go down all the individual rabbit holes and get lost in the details. I'd like to give just an overall perspective on healthcare technology assessment. I do have to give you a little bit of a disclaimer. I might stumble over my words a little bit. I might look a little tired. I might have a raspy voice, but that's because I currently live in Milwaukee and I was up watching a basketball game last night. So that's my excuse. So let's move through the slides here. Here we go. All right, you don't have to read through this entire slide, but I always think it's really important. I know when I hear various webinars, I want to know where the perspective's coming from the speaker. So I wanted to give you that idea. So I have been in the what I would consider the HTM industry for 20 years. I can pretty much say that for certain. It used to be almost 20 years. Now it's 20 years. I started off, I got an electrical engineering degree and my goal was to design music equipment. That didn't work out, so I accidentally got into the medical device field. I worked for GE staging mobile MRIs for a few months. I worked as an in-house imaging service engineer for a hospital system here in Milwaukee. Then I got into leadership and was a like a third-party management for that hospital system in Milwaukee for a number of years. I worked also for an equipment rental company where I was doing biomedical program management for a 4-state region. And then the last 9 years, I've been with Frederick and the Medical College of Wisconsin as the HTM director. Well, I've been the HTM director for the last 3 years. Prior to that, I was more focused on imaging technology, which included our imaging engineering, as well as our radiation physics and uh, radiation safety functions for the organization. As was mentioned, I am also an academic instructor, so I teach a couple of classes for IUPUI's program, their Healthcare Engineering Technology Management program, a Standards and Regulations and a Financial Management class. And I also teach at Marquette University. I am the acting program director for the master's program that I actually graduated from. And I also teach a healthcare technology assessment class as part of that program. And a lot of this material is kind of leaning into that content. So that's my background. And now we're gonna move on to the meat of the presentation here. So I just want to start off really quick, just from the highest level. And I try to start all of my presentations and all my presentations from kind of this concept. And this is a concept I started using in some of my classroom material. And I actually thought it worked out so well that I kind of moved it into my everyday work as well. And it's kind of a guiding outline of how an HTM program works. And it's really looking at one full and complete inventory, one program that applies to everything in that inventory, and one budget that applies to everything in that inventory, so that you know that your program and your budget and your inventory are kind of all in the one, all in the same. So your budget represents everything in your inventory. So that's kind of like the overall framework that I like to try to narrow everything down to. But really, in reality, we all know that life is a lot more complicated than that. And there are all these layers to HTM, and it gets very complicated and things kind of overlap. So we're going to take one little specific layer of the HTM universe, which is technology assessment. So this is what we're going to land on toward the end of the session when we get into the practical application. But I wanted to just give you a little preview of where we're going with this. Now, don't get overwhelmed with this graphic. It looks more complicated than it really is. I'll walk through it, but I just wanted to give you that visual of where we're headed. So what's our agenda? Our agenda is we are going to do kind of two things. The first thing is we're going to walk through something called the 3Q method. And 3Q method, if you haven't figured out, is 3-question method. And those are the 3 questions right there. Is it real? Is it worth it? Can we win? And then after that, we're going to go through some practical application of technology assessment. Now, technology assessment, like, what is that? So in its most basic sense, the way I could phrase it is, it's evaluating technology for purchase or an investment. That's kind of, I guess that's the simplest way we can look at it. When I teach my course, I look at it both from a clinical engineering HTM perspective as well as a medical device manufacturer perspective, because we have students from both industries. This talk will be more specific to the HTM clinical engineering perspective. And really what technology assessment is it's looking at a very methodical and logical approach to evaluating technology rather than guiding by pure emotion. So many of us have stories about a physician or an administrator that'll come to a finance committee and say, I need this is mission critical, it's patient safety, this is a must do, this pays for itself in 1 year, the competition has this, I had this where I came from, a physician might say, or one of my favorite ones is the studies show, and then they give their justification. It's really difficult to take all of these potentially good reasons and make equipment decisions for competing priorities. So what we're going to go through in this session is maybe just some guiding questions of how to move through that process. And we won't get too specific. We'll give kind of the overall framework. But at the end of the session, I'm hopeful that some of you might think once in a while when somebody says the studies show and give their justification, you might actually ask the question, what are those studies? And can you show me your critical review of that research? And then if you do that, let me know how that goes. I'd be curious. All right, so here are the 3 questions. Is it real? Is it worth it? Can we win? And this is taken from a book called Biomedical Technology Assessment, written by Philip Weinfurt. So Philip Weinfurt is a retired Marquette Electronics engineer, which eventually became part of GE. He also happened to teach the technology assessment class that I now teach. And early in my career, he was kind of a mentor to me. He had taught this class as part of the Healthcare Technologies Management Master's program that I graduated from and that I'm part of now. So he wrote this book, and I still somewhat stick to this framework for the class. So this is kind of where I'm coming from when I share this with you. The one thing I will say is that the questions are, is it real? Is it worth it? Can we win? I changed the order. In the book, can we win is the second one, but that's just a minor detail. So let's move through these questions. So question 1, is it real? Does it solve a real clinical problem? Is it clinically tested? Is it based on real scientific principles? All right, so what does this all mean? Let's kind of break this down a little bit. What is the clinical problem? This is where you define the problem. It sounds very simple, but just making sure that you're not buying technology for the sake of buying technology because it's the latest and greatest or whatever that might be, that it's actually solving a particular clinical problem. And then also understanding what that clinical impact is. Is it something that's going to impact hundreds of thousands of patients, or is it going to impact 10 patients? You know, what is that projected clinical impact? Just because there is a problem, it doesn't mean that it's a significant problem or a big problem or a small problem. You have to kind of parse that out. And then another thing I'd like to mention about this is that just because it's better technology doesn't mean that it's necessary technology. The example I like to give is I had bought a flat screen TV years ago and it lasted forever. It was a 720 resolution, and eventually it went bad and Super Bowl was coming up and I needed to buy a new TV, and I went in and I'm looking at all these TVs and I see the 1080 TVs and I see the 4K TVs, and the 4K was just kind of gaining some traction at the time. And they're trying to sell me this 4K. They're like, this is the latest and greatest. You're going to want this for the best experience. But I'm thinking, I'm coming from a 720. You're going to move me to a 4K. I can do a 1080 and not really know the difference. Plus, I don't really have anything that broadcasts in 4K at the time. So I was like, 1080 is fine for me. So the point is that just because it's better doesn't mean that it's absolutely necessary. And that applies for medical equipment as well. And then just understanding whether it creates new problems or not. So new problems might be you buy the equipment, it sounds like a great idea, but you don't have the staffing for it. You don't have the workflows for it. There's compliance issues for implementing it, things like that. So let's pretend like you established that it's a real clinical problem that you're solving with this potential technology. Then you have to ask whether it's clinically tested. So normally when we talk about a test with medical equipment, we're talking primarily about diagnostic or screening tests that lead to a clinical decision. There's other tests as well, but that's primarily what we'll be kind of focusing on. There is some reading for you, a book. I don't know what the latest version of this book is, but Studying a Study, Testing a Test is a potential further reading for you. But essentially, we're trying to establish whether this technology that's going to solve a problem that we established really has been tested. And how do we test equipment? that would be through clinical research or clinical trials. Now, if I was teaching this in a multi-day session or a full college course, we would go through the different methodologies, and here's just a few examples of them, methodologies of clinical research and the pros and cons and things to look out for. Just a couple of general points just to give examples of some of the things you'd look at critically in clinical research is it retrospective versus prospective? So retrospective means the data was collected. Now I'm going to go back and make conclusions based on the results of that data. You can't really control for variables because the work's already done. Prospective would be you set it up, you can control the variables, and then you can systematically measure going forward what the results are. Randomization is another example, making sure that your patient populations are randomized so that it's truly, it's not cherry picked to the point where you're going to affect the results by not representing the full population you want to test. Blinding is another thing, making sure that if at all possible, it's not always possible, but that the patients involved don't know if they are receiving the treatment or the technology versus not receiving the treatment or technology, so that they don't introduce a bias based on what their preconceived notions of what the results might be. That could also apply to physicians that are doing interpretations. You may want to blind them as well so they don't know who are being treated and versus who are not being treated, as in the control group. And you're trying to eliminate the possibility of biases in this. So these are examples of things to look out for in clinical research that we're not going to do a deeper dive into. But speaking of bias, this is an important piece that I want to just expand on a little bit. What is bias? So bias is the systematic tendency to deviate from the true value. I also want to just mention that accuracy is the absence of bias, and I just share that because I just love that definition for whatever reason. It's just kind of neat. So the questions you ask around bias are who sponsored this clinical research or this trial, and who conducted the research or trial? Was it the company who is developing the technology, or was it an independent body? But I will also say that just because the company who is developing the technology is the one that sponsors or conducts the research doesn't mean that it's bad. It doesn't mean that there's bias in it. It just means that you have to take that into consideration when you're looking at the overall methodology to see, is there any place they may have entered some bias in unintentionally? Other examples of bias might be participant and data omissions. So when you're evaluating clinical research, a physician says, the research says, here's the result. Well, if you look at the research, if it's possible that a lot of times you'll read through and they'll say, okay, there were 100 participants, we had to eliminate 10 participants throughout the clinical research. And there might be good reason for that. They couldn't complete the research for whatever reason. They had a family emergency, they had I don't know, any number of things, or they weren't compliant with the particular protocols that needed to happen. But then you have to kind of question the study of, was omitting those helping the study in the sense that it was omitting erroneous data, or is it actually skewing the results because you're pulling out potential people that may impact or represent the real population you're trying to study? One other example I'll give you of bias is publication bias. I had heard many years ago, and I play this this news segment for my class, is on NPR. There was a segment on that basically outlined that typically research is publications tend to publish research that has positive outcomes versus negative outcomes. And what I mean by that is, if you're doing a study and you're trying to prove something and you prove it, you're more likely to get published than if you were doing research to prove something and it didn't work out. Then you're probably not going to go through the process of publishing because it's not as exciting. So one thing to look out for is, if you're looking at clinical research on a particular technology, if you find a couple of studies that say, yes, this is valid and here's the results, you may want to do a little bit more digging to see were there any studies that maybe didn't hit the mainstream publications that were conducted, and did those say something else? So that's just another example of potential bias. So just in general, there's multiple different types of literature that's available for evaluating technology. Sometimes the best you have is the vendor sales material. Now, if there's vendors, sales reps on this webinar, I'm not poking fun at you or anything, but we can't always trust the bullet points on the pamphlet that we're handed, or the high level statements that are on the email that we're getting sent to us. We can't always take that as our clinical research guidance. We have to look a little bit deeper than that. It might be a vendor sponsored study, but ultimately what we would like to get to for healthcare technology is what's considered a multi-centered study. So that means it's not just done in one place, it's done in multiple places. Prospective, meaning we set up, we put controls in place, and we're gonna look at the results. Randomized, so we know that it represents the population we're trying to study, and that it's in some sort of a publication that's peer reviewed by outside individuals. That's kind of the ideal case, not always possible, but that's ultimately the gold standard, what you're going to want to look for. So the evaluation of the technology from an is it real perspective and for this clinical research can follow what's called the MARIE framework, and that's an acronym. We love acronyms. The method is the M. So that's looking at the establishing that study population. Assignment is how do we say who's the control group versus the study group? How do we separate those two groups out? Assessment is evaluating the outcomes of those two groups. Results is comparing those two outcomes. Interpretation is looking at the conclusions. What conclusions can I make based on those comparisons? And then extrapolation is, even though I got these results within this study, can I make any leaps to say that this applies to the greater population that I'm trying to study? Sometimes that's not an easy leap. So this is a framework you can look at, and you can look this up. There's information, just you could search for it online to find more detail. And like I said, if we had a full course on this, we would break each of these down and figure out how we would go about looking at each of these items. But it's a very systematic, logical, objective way of looking at clinical research, and it kind of takes the emotion and rather than just taking the summary and skimming off the conclusions off the top, you're actually looking at the makeup of the study. So that's the is it real question. So is it worth it? We'll go through this pretty broadly. It's pretty self-explanatory, but I just want to make a couple points. So is it worth it is the financial analysis. So it might be real science, but now we got to figure out, is it financially viable? So we're going to look at revenue, expenses, and ROI, which is return on investment. So revenue is the money coming in. There's some simple questions to ask, like, can we even bill for this technology? Back when like 3D mammography was coming out, there was this big question as to whether you could actually charge for those particular scans, and a lot had to be worked out in the industry with that. So new technologies in particular, you have to figure out, can I even bill for this? If it's an image guided procedure, can I bill for the image guided component of the procedure? So those are some questions to consider. And then if you've been around healthcare for a while, you probably know that what you bill isn't always what you get. So how much will you actually get paid has to be taken into consideration. So what you invoice isn't always what comes in, depending on reimbursement rates and patients' ability to pay. And then evaluating the volumes. So how much am I going to get paid per volume, and then what's my volume going to be? And I'll have some more to say about volume in just a minute. So that's money coming in. Money going out is expenses. So you want to look at the total cost of ownership. So here's some examples of what that looks like. Not just the purchase price, not just service and maintenance, but all of the costs, supplies, and potential staffing costs or utilities or infrastructure costs associated with the technology. So if you want to dig more into the finance side of things, I actually did a session at the HTM Mixer in Milwaukee back in October on financial management. So I talked more about this, so you could go back to that if you needed more information. But capital expenses are the non-routine things. So if you have a house, it's like your appliances or maybe a renovation of your home. It's putting value into your organization. So this would be like buying equipment. Whereas operating expenses are the routine costs, the monthly bills or whatever it might be. So you have the money coming in, which is revenue, money going out, which is expenses, and you want to figure out the return on investment. And this is where I want to make a couple of distinctions or points here. So basically ROI is how long does it take to break even? And you figure out money coming in, money going out, and when's that break even point over time. And those expenses, remember, is not just purchase price, it's also taking into consideration your expenses and whatnot. But you got to remember, most healthcare organizations are competing for priorities here. So you have multiple requests for technology that are all trying to get the same money. So breaking even isn't always necessarily the best threshold. So you may want to look at not just breaking even, but how long until you see a gain. So maybe it's how long until you reach 150% of that return on investment or something like that. And then the last question I want to mention is, I think this is often overlooked, is what happens after the return on investment. Sometimes a great case can be made that if we buy this equipment, return on investment would be 1 year. But then you think through it a little bit, okay, do I have a very limited patient population? So what happens if I treat all the patients in my market that need this particular technology? Okay, I made my return on investment, but now I don't have any more patients. So does that make my decision different or not? Maybe it doesn't. Maybe you still invest in it, but just thinking long term, it's not just break even, it's what does that long term outlook look like? And then the last question of our 3Q method is, can we win? Now this one's a little bit more theoretical, I guess, or maybe it's not as analytical. It's looking at the strategic fit. It's also looking at whether it's within our expertise and can we be competitive. There have been projects that my students have done in some of my classes, and I've seen some examples in the industry that I work in that it may make financial sense. It may be a scientifically proven technology and on paper may look like a good idea, but from a strategic perspective may not make sense. And that's where this piece comes into play, the can we win. So this is where you want to look at your mission, vision, and values and figure out, is this investment that we're about to make, this purchase that we're about to make, or this type of service we're about to provide, does it align with who we are as an organization? An example could be like McDonald's is never going to come out and say, we're going to transition all of our restaurants to farm to table establishments. It's just not going to happen, because nobody would believe it, because that's not who McDonald's is. Nobody would believe that that's what McDonald's would do. It's just not, it's not strategically, it doesn't strategically make sense. Now, if that ever happens, I will literally eat my hat. So let me know if that ever happens. Another example, I believe this example comes from one of Simon Sinek's books. I think it was his Start With Why book, but he had talked about how Dell Computers came out with an MP3 player at the same time when Apple was getting their iPods off the ground. But for whatever reason, Dell was viewed as being a desktop computer company, not a media company with MP3 players and music and whatnot. Whereas Apple was able to establish being a technology company and having that media component and was able to take off. So, you know, it was the same technology, but it worked for one company, but not necessarily for the other. And then can we be competitive? So how big is the market that you're competing in? If you're buying a technology, you're going to draw in a certain patient population. How big is that market? Is there market to gain? So even if you know, are there even patients available for you to pull into your market? And is the market temporary? Kind of as I mentioned before with the volumes, um, once we get through the patient population that we're targeting, does that patient population dry up, and is that service no longer needed, and does that impact our decision? All right. So we just went through the 3Q methodology, and it's very theoretical. I know that there's a lot of detail behind all of that, but you kind of get the basic sense, hopefully, of what the 3Q method looks like. So it's looking at, is it real science? Is it financially feasible? Can we win? And then is it a strategic fit? I'm sorry, is it worth it? And then can we win? Is it a strategic fit? So now what I'm going to do is I'm going to go back to that original graphic that I threw on the screen. Um, I almost said threw up on the screen, but then that never comes out right. So I threw it on the screen, and we're going to walk through this, and this will give just some practical ways to apply some of these concepts, but you don't always need to apply all of the concepts. So hopefully you'll see what I mean as I walk through this. So here's the big picture, and let's break this down into pieces here. So we'll take this part of the flow chart here. Now this is not part of that 3Q book. This is a flow chart that I'd put together, but it's based on some of the same concepts. So essentially this part of the flow chart, we're talking about replacing one of the same piece of equipment. So you have all this equipment in your organization, and at certain times you're going to have to replace because maybe the equipment is damaged beyond repair, or it's going to cost more to repair it than it would be just to buy a new one. So this is pretty routine replacement of equipment. That's the scenario we're talking about right here. So in that case, I would suggest that you would do a service assessment. And what does a service assessment consist of? Well, serviceability, so looking at metrics around downtime, mean time between failures, those types of metrics. So are we able to service it? Reliability, do we have access to parts? What is the useful life? Can we fix it? And then safety and risk. Is there a specific safety concern or risk outside normal expectations of the technology? So this is a service assessment. We can all kind of think through this, and this makes sense because this is something that we do very often. It's very routine. So routine replacement. But now, okay, so maybe we're not replacing the equipment, we're adding additional equipment. So it's stuff we already have. Maybe it's more infusion pumps or more ventilators. We already have it, but now we're going to figure out we're going to buy some more. And you're probably thinking, well, then why do we need to assess it if we already have it? Well, if you're adding equipment for growth, you're adding to that existing fleet, I would suggest you do a utilization assessment. Often in HTM, people come at us and say, cut down your service costs. And my first response always is, or it should be if it isn't, is the best way to reduce service costs is to reduce your equipment load. So before you add additional equipment that you think you need, do a utilization assessment. And what does that look like? You look at your volumes, your current volumes and utilization. You look at projections going forward, and you look at your productivity. I think this is something that's very often overlooked when evaluating equipment plans and assessing technology purchases, is that often we don't look at the utilization close enough to say we could shift patients here or there, we could share equipment before we just jump in and start buying equipment because somebody says we need more equipment. Maybe there's a way to do things more efficiently. So that's a utilization assessment. Now we'll move to the next column here. So this is new equipment. And what I mean by new equipment, it's a new device. So it's adding, it's the technology you already have in your hospital, but you're adding a new model or something that has a little more functionality. It's not just replacing something that you already have or adding something you already have. This is looking at some new product. So it might be a new vendor, it might be a new model of that vendor. And in that case, you would do a product assessment. And I think this one we all can kind of relate to as well. Product assessment would be doing a clinical review, so have some sort of clinical advisory groups of subject matter experts, the people that are going to use the equipment. And that might look familiar. That might be a little bit of that, is it real? Then you do a business review. That might be finance and supply chain. And obviously HTM is scattered in all of this as well. And that's kind of the is it worth it discussion. And then you want to do a technical review. So between HTM and IT and others, looking at things like device integration and serviceability and the things that we live and breathe, doing sort of a technology review. And this would be a product assessment. A couple points on product selection under product assessment. Some key questions asked is, first of all, what do we need? Like, what are we trying to accomplish? What are our options that are out there and what's the best solution for us? Remember, just because it's better doesn't mean it's necessary. So two key questions to ask, which are often overlooked because usually we're making these decisions quicker than people want to do an assessment, but you need to ask, what are the needs or must-haves versus what are the wants or desires? Here's just an example. It's just arbitrary kind of criteria. I think it was kind of an ultrasound example that I had at one point, but basically you list your must-haves and the various options that you're going to purchase. Like option one would be one vendor, option two another vendor, or option three maybe it's the same vendor, just different model. Maybe they're all the same vendor, different model. But you're carving out what do I have to have versus what are some of these nice things to have. Because otherwise, if you just take all of the criteria and wrap it up into an evaluation, you're gonna have a hard time comparing apples to apples of what do I really need versus what I don't need. If you establish that up front, you establish that criteria, it's a lot easier to make a decision and kind of check the boxes. And maybe you don't do that product assessment for every purchase, but for the bigger purchases or the more important ones, that should be the process that's followed. All right, and then the last column here we have is new technology. So when I say new technology, this is something that your organization currently doesn't have. It's like, back in the day before we all had robots in our hospitals. Well, maybe not all of us have robots in our hospitals, but robotic surgery, that's a big thing. It's like, this is something new that I don't even have anything currently to compare it to. Or maybe like a PET CT scanner or something like that, where it's just like, yeah, it's kind of some of the same technology, but it's something very different than what we're used to dealing with. So that's this new technology column. And in that case, you would do theoretically a full technology assessment. And that's digging into more of not just the technical and clinical aspects, but the business aspects. And so like we reviewed at the very beginning, you're looking at is it real? So real problem, clinically tested, real science, and validate that science. Is it worth it? Looking at revenue, expenses, return on investment. And can we win? Is it a strategic fit for us? Is it within our expertise? And can we compete in the market? So here's that picture again. Hopefully it doesn't look as scary and intimidating as it maybe did in the first couple of slides when I presented it. But hopefully you can get the idea of there isn't necessarily a one size fits all technology assessment. There's probably different workflows or different assessments for different scenarios. But I do think that the 3Q method in particular is extremely helpful. If you talk to any of my former students, or even any of the students that took the class before I was teaching it, I think a lot of them will tell you that they carry on a lot of these concepts in their daily work, whether it's the full technology assessment framework. Maybe it's the Marie methodology, but maybe you're not really into the clinical research as much, so maybe you take pieces of it. But just understanding that there is a critical way to look at these requests, and it's not always the passion and um, the drama that sometimes these requests bring into the discussion. There is a methodical, logical way to approach these assessments, and it's important to kind of um, be even-minded about all the requests that are coming in and make a very educated uh, decision as to what you're going to use your limited funding for. So I know I just went through, like I said, skim the surface of technology assessment. Down the road, if there's interest in various like aspects of this to dig in deeper, I'd be happy to do that. But I wanted to make sure I got through the full kind of gamut of things. If you do want some additional information, this is not really an advertisement. This is a podcast that I created. It's basically from the material that I use from a lot of my classes. So I'll use some of these podcasts in my classes. It's completely free. I don't make any money off this. I do it kind of for fun, and I like to share information like this, but I do dig into more of these concepts, and I try to make it a little bit entertaining to some extent. So feel free to tap into that. It's the Paradigm HTM podcast. You should be able to find it just about everywhere that you get podcasts. I think that's what I'm supposed to say when you talk about podcasts. You can get it wherever you get your podcast. So I have reached the end of my material. I will pause for questions here, but just also on the screen here is my contact information. I will just say I wear a number of different hats, as I explained at the beginning of the session. Probably the easiest way to get a hold of me might be to initially message me through LinkedIn. If it's something that's related to my work with Freighter, my normal day, I call it my grown-up job, you can email me at my Freighter email address. If it's something related to my work with Marquette, you can email me at my Marquette address. But some of the work that I do is between those organizations or IUPUI, or if it's just general questions about, career situations or just general kind of discussion, you can message me through LinkedIn. With that, I believe I'm ready to pause for questions.
Thank you so much, Matt, for a great presentation. I do have a reminder for the audience that if you have any questions for Matt, please use the questions feature on your GoToWebinar dashboard to submit your questions. We do have some that have come in already, Matt. We'll start with, how do you handle unplanned urgent replacement requests when a system is down and there is no time to do a full assessment?
That's a key point that I did not touch on. So I did mention that often we're making decisions from emotion and from kind of split-second decisions. I think the key is that you need to establish a technology assessment methodology ahead of time, so that as these requests come in, that you're able to swiftly evaluate them in the time frame that's reasonable. But the one thing that I will mention is with emergency requests for replacement of equipment. Let's take that example. Just because you have the equipment now and it's down and you no longer can use it, it doesn't necessarily mean that you have to replace it. I know that's a tough concept to swallow sometimes, especially if you say that to somebody who is requesting it. But here's, if you step back just from a logical perspective, is we looked at that utilization assessment. If you have three of them and one goes down and now you're saying I need another, well, do you really still need three of them? Can you get by with two? Is it really necessary to replace it? The other point to make on this is if if you think it's really important, you need to replace this. Yeah, bring it in for a request. But then as a committee, the committee needs to look at, or whoever's making the decision, the committee needs to look at what are all the requests that are sitting in the queue. There might be some routine requests that are sitting in the queue that just have not been approved yet, that are actually more urgent than the urgent request that was um, just provided. It might just be a difference in emotion, or just kind of like the squeaky wheel syndrome. So I think those are key concepts to think of. Establish your technology assessment methodology up front, and always ask the question, do I really need to replace this? And do I have other priorities that might be just as much of an emergency? They just aren't getting the attention.
All right, our next question is, do you rely on the doctors and clinicians to review and analyze clinical research?
Yeah, and that's an important one as well, because if it's hard to look at, if you're going to review clinical research, you probably want the subject matter experts to be the ones reviewing that clinical research. It makes sense, right? If you have a specific technology expertise, you're probably going to be the one to evaluate that technology versus someone that doesn't have that expertise. But I will say that there is some value in having fresh eyes and maybe people outside of that circle of expertise as part of the evaluation process. So I think the 2 points I would make is, if there is a clinician that is doing an evaluation of clinical research, there should be an expectation, and maybe even a way to validate that they've taken a non-biased kind of critical review of the methodology of that research, and didn't just take, like I said, didn't just skim the surface and take the takeaway off the top of the abstract of the research, but actually looked at, does this clinical research make sense? And maybe that physician isn't necessarily the one to evaluate that clinical research in that way, and maybe there has to be someone that has more expertise of going through that kind of methodology. But then I'd also suggest that the review process should be multidisciplinary, even looking at clinical research. Yes, the physicians, clinicians, the practitioners that are using the equipment are the experts from that perspective, but having that outside perspective and maybe asking some of the, I like to call them some of the stupid questions that you think are stupid, but they're not really. Um, I think that's a really important part of the process. And like I said, you don't have to do this for every single request coming in. It's you got to pick and choose what you have resources to evaluate, but definitely the bigger decisions you make, you want to take a good look at the how valid that science is.
Thank you again, Matt, for your time today and for a great presentation. I would like to encourage everyone in the audience to visit today's sponsor to learn more about the services they provide to our industry. Please visit mtmi.net. A quick reminder that you can obtain your continuing education certificate by completing the post-webinar survey. The survey will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your continuing education credit from the ACI. You'll be able to download your certificate immediately upon completion of the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll be back next week with another webinar. Please visit webinarwednesday.live for more details and complimentary registration. Thank you all and have a great day.